Hi guys, so this is going to be an educational video for the budding anesthetist and as well as for the emergency physicians. So this is regarding the concerns and risks involved while shifting a critically ill patient from one state to the another. So it needs meticulous planning, communication between the transferring doctor and the receiving doctor as well as patient relatives regarding the patient's clinical condition, the course in the hospital and the reason for transferring, and so as well as an informed consent which has to be taken by the senior doctor himself or herself. So the risk and the benefit has to be evaluated and explained to the patient bystander before shifting. Here, I would like to share my experience in shifting a polytrauma patient from Bangalore to Kochi. So, on the day prior to shifting, A, B, C, D of the patient has to be assessed. His airway should be assessed, Ryle's tube need to be inserted, and C spine should be examined. Coming to breathing, room air ABG for the parameters of the lung can be assessed, ventilator setting to be noted if the patient is tubed. Coming to circulation, 2 wide-bore cannula should be inserted. In case of hemodynamic instability, central venous catheter and arterial line are advised. Coming to disability, GCS should be assessed. Calf Doppler to rule out DVT should be done, and low molecular weight heparin to be started if not contraindicated, along with compression stockings. Advanced life supporting ambulances, it should have 1 specialist doctor and 2 competent staff members to manage the patient. It should be well equipped with facilities for endotracheal intubation and ventilators, cardiac monitoring including ECG, NIBP, pulse oximeter and temperature, and defibrillator, and oxygen cylinders with pressure gauges, and infusion pump for vasopressors and sedation. Glucometer to check the GRBS hourly, and trolley bed. All medications including sedatives, analgesics, inotropes and resuscitation drugs need to be checked prior to transferring of the patient. Shifting was planned during the daytime, as in any unanticipated complication needing immediate hospital care on the way could be easily sought for, and hence the list of major and minor hospitals on the way was noted. It cannot be overemphasized that the documentation of GCS, vitals, lab values, ECG prior to shifting of the patient must be noted. NPO status was maintained to prevent risk of aspiration. Blood glucose level was monitored every hour, and fluids were changed accordingly between ringer lactate and DNS. All the electrical equipments needs extra backup with extra batteries in hand. At best, brakes function to promote and restore attention, efficiency, physical stamina of the medical professional. So prior to start of the journey, we planned who should take brake and when, how long the brake should be and where the brake should be. Some problems: headache, pain at the fracture site, nausea and vomiting which can lead to risk of aspiration. Hence injection ondansetron and an intermittent Ryle's tube aspiration was done. Vibration absorbing mattresses and padding all contact points between the vehicle and the patient was taken care of. And another problem was temperature and humidity. The air conditioning inside the ambulance can lead to hypothermia. Hence, the patient should be properly covered with warming blankets, and artificial teardrops for the eyes are needed to moisturize. Now you can pause the video and go through these tables. So this is a short video emphasizing the concerns and risk involved in transferring a patient interstate via roadways, and my references are given in the description box. Thank you.